we started the, yes, okay, not that. Click, got it, fine. Talking to the computer. Yes, so we are in a second year of these events, which we, after several months of discussion, called District Dialogues, Issues of Race and Justice in Our City. We started February of 2021, talked about many different topics, and we will be working on covering issues of inequities in our city, as long as it takes. So welcome, Dr. Arno. Susan, you want to?
Yeah, I want to welcome Dr. Anneta Arno. She is has a master's in public health and a PhD. She's the director of the Office of Health Equity at the District of Columbia Department of Health. And it turns out the district organized this office or created the office in 2015. Now, Dr. Arno is an experienced public health professional with a track record in the field of health equity. This includes work promoting community collaboration to transform views and perspectives related to root causes of health disparities, the integration of health equity concepts into healthcare delivery systems, and racial equity through a public health lens. She's had previous leadership roles in communicable disease prevention and public health preparedness in the City of Kansas City Health Department, the Center for Health Equity in Louisville, Kentucky, and Metropolitan Department of Health and Wellness, and at the University of Louisville School of Public Health and Information Sciences. We are so pleased to have her tonight. She has a city-wide mandate to do something, and we're very interested in what's going on in our city in terms of the health disparities and what can we do about it, or what is being done about it. So we're looking forward to her talk tonight, and I'm hoping she'll tell us something about herself too. So over to you, Dr. Arno. Appreciate you coming.
All right. Well, thank you so much. I'm delighted. It's a great pleasure for me to join members of the community. In fact, when I was invited to speak, I did not know the subtitle of your group that says Issues of Race and Justice in Our City. I don't think I realized that. So I'm excited to know that that is your mission. I'm going to try to share my slides right now as a starting point. So that, oops, I shouldn't be starting there. I should go to the beginning and start here and put it in.
You have to do this with slides.
From current slide. Okay.
Only one's coming up.
So, so thank you so much for having me. You did ask about me. You did read a little bit about my background. I was actually born in England. I grew up in Guyana in South America. I think I moved to Canada in the early 90s, and then not much longer after that, I moved to Louisville, Kentucky. So that is my background. I moved to DC to take up this job at the end of 2015 after the new office was formed. So I bring my experience of leading the first of its kind actually in the US Center for Health Equity in Louisville. And then all of my other experience and background and I think to some extent even living in other parts of the world informed some of my perspective on some of these things. So that's about me. I don't really like to talk about myself a lot. I love to talk about people. I love to talk about my work. And I'm actually very delighted to be here. So I know I have a lot of slides. I will go slow and then I'll go fast and then I'll go slow, right? So just be prepared. If I'm going too fast, just slow me down, okay? All right, so the title of my my talk, and this is in fact my mantra, health equity is everybody's work. So when one or two are gathered, big rooms, small rooms, whatever your job in our city, you are part of the work, right? You are part of the work either by, I usually say by commission or omission, or somewhere in between. So we all have a role to play. So I'm always delighted to speak to community members. So here's at DC Health, Our mission is to, well, actually, I should talk about the first. We are really trying to build a culture of health and equity in the District of Columbia. Our vision is to make the city the healthiest city in America, and our mission is what's written here. So we promote health, wellness, and equity across the district, and we to support all the residents and visitors who do business here. So equity was added in 2015 or early 2016 after I got here, because this is what we are committed to. And so this work is not new, but I always say it's patient work, right? It doesn't happen overnight. The problems of inequities were not created overnight. They're in the US, they've probably been created over 400 years. And so undoing them and unpicking them will take us, hopefully not quite 400, but it will take a while, okay? So this is what we see ourselves as doing. DC Health is not what I call your traditional public health department, definitely not the 19th century or even the 20th century model. It's definitely a 21st century public health department, and we see ourselves as the chief health strategist for the district. We don't actually, even as you saw with COVID, we are not the ones sharing vaccines and those kinds of things, which I know happened in Kansas City and some other places that I've lived. We basically think that everybody should have a good and a well-placed relationship with their healthcare provider. So they should have an open conversation. And so we don't try to get in between that, except where there are places for things like TB, HIV, et cetera, where there is not a lot of bandwidth to do those things. So what that means is that we take care of our city and of our residents by ensuring we are regulators. So we regulate the doctors and the hospitals and all of those folks in the district. So that's our major role. And you probably saw us do a lot of regulation during the pandemic, but ultimately it's to ensure that we have, that all the folks who come here to work are doing the right thing. So we try to be a role model in what we do. So health equity is one of those things, as well as a convener and a collaborator, right? So we have roles where we lead, but collaborating, et cetera, really important. So the 5 strategic priorities we have are promoting a culture of health and wellness, addressing the social determinants of health, strengthening public-private partnerships, closing the chasm between clinical medicine and public health, and implementing data-driven outcomes approaches to programs and practice. So notice I said, these are the 5 strategic priorities for DC Health. Social determinants of health and health equity are not only my job. A lot of where my work comes in is to not only build a foundation, but to focus externally with collaborating partners. So you'll see why that is. One of the big things that was achieved since I've been here was releasing the inaugural health equity report for the District of Columbia, which was released in February 2019. Not about a year before the pandemic. What we did was we took the show on the road, we talked to a lot of people, we started thinking about what needed to happen. Now we have the report out. A report on the shelf is not going to make things change. So I'm going to give you some of the background. The focus of the report is not what people would normally think. It's not about healthcare. In fact, it's not healthcare centric at all. We have these 9 key drivers. It's a new framework that we're applying. We're looking at education, employment, income, transportation, food environment, medical care, of course, which we regulate, the outdoor environment, and community safety. We look at it not just in wards, which has been the traditional way that we think about things, but in fact, we do the data and analysis to a much more granular level, to the 51 statistical neighborhood level. And they're not so you will see Capitol Hill maybe in one of those, but it doesn't mean the traditional Capitol Hill. It's a statistical neighborhood. And the reason why we give them names is because I don't think if I say to you, statistical neighborhood number 1 or 51 or whatever, you would have no idea where I mean. So the names are more to give you a sense of where they are. We do mostly a lot of our work is correlations with life expectancy at birth, and we look at the social and structural determinants of health. Now, the reason why I'm saying I focus on the 80%, the non-clinical determinants of health. I've got the whole rest of my health department focused on the healthcare and the tradition, what I call traditional healthcare kinds of things, which is only 20%, which is clinical care. So this is the donut. 80% of the donut happens outside of traditional healthcare and public health. So these are the key drivers that I've learned along the way since I've been doing this work for over a decade and before. Health is more than healthcare, as evidenced by the donut. Health inequities are neither natural nor inevitable. And I'll say that over and over again. So despite what people say, we may all look different outside, but 99 and a lot % of our genes are the same. So our external, what we look like are just, phenotypical. They're not necessarily anything to do with, so your zip code may be more important than your genetic code for health. The choices you make are shaped by the choices you have. So if you live in Capitol Hill and you have the choice to attend this meeting and that's the way it works. But if I lived in some other neighborhood and we didn't have these convenings and we were not thinking about issues of race and justice, I'm doing something else. I may just be sitting around with my colleagues or my friends and eating popcorn, right? Not necessarily expanding my brain and thinking about these things. So that's an idea of what this works like. Structural racism acts as a force in the distribution of opportunities for health, right? So this is one that's frequently people are very kind of shy about saying. We have not been shy about saying it. There is strong and consistent, and I think underscored by the pandemic, that structural racism is alive and well. And from that perspective, all policy is health policy. So when I showed you the 9 key drivers, I'm really saying that education policy is health policy, transportation policy is health policy, et cetera, et cetera, et cetera. So that's really what this whole dialogue is about. You'll hear about and see many frameworks, which will talk about population health drivers and social determinants of health. And this is where I kind of bring in some of my past experience. So we frequently talk about the social determinants of health and people think about, well, food insecurity. Well, that is definitely a concern, but the insecurity is not because of lack of food in America or in DC, right? In fact, we throw away a lot of food. It's some other things that put people in a position that cause them to be food insecure, right? So we may put these things into buckets and we may say that clinical care is 20, health behaviors are 30, socioeconomic factors are 40, and physical environment. But even the health behaviors, when people smoke, whether they exercise or diet, and et cetera, if the doctor says you need to walk 6 miles a day and you live in a context where either there are no sidewalks or it's too dark and or it's not safe, you cannot. So that's where we see that there is a direct connection between the social context in which you live and whether you're even if you know what the right thing is to do, you may not be able to exercise that choice. So that goes back to the choices we make are shaped by the choices we have. So the model that I use in producing the health equity report goes back somewhere in this chart, looks at the county health rankings, but really it's the structural drivers, the history, the values, the public policy, the laws, the societal conditions that we as a community accept that actually create this context, right? In a different country, in a different place, these percentages might vary. So if you look at the WHO, you'll see them talking about distribution, whereas we tend in the US to talk about causes. And we think the simple solution is, give people a little bit of food rather than figuring out how to solve the structural barriers that prevent them from having access.
Yep.
So finally, this is the other thing. Even though in the 60s, we went through a whole lot of changes and we took away all the rules about discrimination. When we look back at, this is the 2011 to 2015, and we see that DC is one of the most segregated cities in the country, right? So on the right-hand side, number 1, non-Hispanic white populations. And so each of these maps, you're seeing orange bleeding out red bleeding out to orange and yellow, where we have the most dense population of non-Hispanic whites to the northeast, kind of filtering out, and then very few in the southeast. The opposite is true for the non-Hispanic Black population, Then when you look at number 3 and we look at the Hispanic population, they're concentrated up in the Northeast. And then for the non-Hispanic Asian, it's a different number. But again, yes, there's nothing that says people can't live wherever they want, but there's some other things that underlying drivers, income, wealth, and all the other things that prevent folks from living, even in this small place called the District of Columbia of just 61 square miles. And it would take 70.9% of us moving if we were to try. I'm not advocating that, but I'm just telling you the extent of the segregation in this city. And I'll give you the number. In Louisville, Kentucky, it was 50, right? So we are much more segregated in many respects than many other cities. So what does all of those things mean in terms of life expectancy at birth? I know that was some of the discussion that you may have had. So we have a 21-year difference in life expectancy at birth. And so you're seeing the same kind of thing here, except it's just red and pale peach and almost kind of just very light, almost beige. So for the most advantaged, and I'm just going to use the word advantage, neighborhoods, some neighborhoods have a life expectancy of nearly 90 years, while others are less than 70. And if we were to simply, and this is by doing the analysis by the 51 statistical neighborhoods, if we only look at the wards, we see a 15-year difference. But what this is telling us is that we live in circumstances where we live in a very granular sense. We tend to live next door to people who are very much like us in terms of race, income, and wealth, and all of those things. And it also means that access to services, etc., and resources are similarly located. Now, I showed you the 9 key drivers. I'm going to focus on this first one, which is education, and then I'll fast click through all the others because it's the same pattern over and over again that end up in the 21-year difference in life expectancy. So again, working to the 51 statistical neighborhoods, we can look at where do folks have bachelor's degrees or higher. And here's the same kind of story, the darkest purple are where people haven't. So we have neighborhoods where 93.8% of folks have a bachelor's degree, and then others where it's less than 16%. And then where we've hashed it out is that there's so few people that we cannot reasonably publish the data. So it's suppressed, not because we don't want to share it, but it's just a statistical way of presenting the data. On the other side, we're looking at folks who are living with less than a high school diploma and living in poverty. And we're seeing almost the opposite. So do you see the mirror image? What the dots on the map shows are life expectancy. So the larger the dot is the longer the life, and the smaller the dot, the shorter the life. And so do you see the correlation between length of life and education, right? And I hasten to add that this is not because these folks are not educated enough to do the right thing and understand what they need to do. It's complicated, it's not simple. In the middle, we have 4 bars in a chart. And what that is telling us that folks who have less than a high school diploma, nearly 40%, report having only fair or poor health. And then when we get to college graduates, very few people are saying they have poor health. And in between, we have a smaller number, right? So there is this stepping stone down or actually increasing poor outcomes for people who have less education. And I hasten to add, it's not because they don't know enough to be able to. It's a very complex. So the same thing, and there are many more slides in the health equity report, but the same thing happens when I show you employment. You see the pattern repeating itself, right? Where the dots are, where the dark 97% of folks who are employed, 15% who are unemployed. And then if you look at unemployment, you're seeing that even though the rate of unemployment is much lower in the district, it's significantly higher in some parts of our city. We can look at the actual income, median income, and this is the 2015 from BRFSS 2015, but we're using 5-year estimates. These are from the health equity report that we published. We use 5-year estimates. We're going to release a new report not so long from now. Because of COVID, things were just churning too much and we were waiting for the 2020 census data to come out, right? But you can see that folks who are, yeah, yes, we have an average income in the district of, in this chart, of 70,000, but it ranges from 40,000 for African Americans all the way up to 115,000 for non-Hispanic whites. We can look at housing in a similar way, and we can see correlations. Usually we, all of us who live here, in our heads, we think, oh, housing is a lot cheaper in the east end of the city, etc. But what we are seeing on this chart, in fact, is that because of their income, even though it's cheap relative to other parts, because incomes are so low, they are paying a higher proportion of their income than anywhere else. So DC has a very high housing cost rate, but we see that there are in some neighborhoods where nearly 60% of residents are paying more than 35% of their income on housing. If you add on to that where they live, and you'll see cost of transportation, people who have, because they're spending that much on housing, they don't have a car, but they're also living in circumstance where there's very not as good quality transit, and they might have to take 2 or 3 buses to get anywhere they needed to go. So here's the transportation map, and we can see where the main transit lines are. You see they all come to the center of the city, but they're very disparate elsewhere. And yes, people will say they're bus lines, but buses are not very convenient for going to work, coming back from work, and just managing one's daily life. And then we can see the relationship. What we're seeing actually in these maps, we're actually coloring the number of residents who do not have access to a car, right? So what we're seeing here is that we have a lot of folks who don't have access to a car, and we can see that there's also a correlation between access to a car and life expectancy at birth. We can also look at food, the same patterns. So it's the same patterns over and over again. On the left-hand side, what we're mapping here are statistical neighborhoods with no grocery stores, right? So the bright left, the kind of burgundy, deep red on the left-hand side, that's what it's showing. They may have convenience stores, but then in some other areas, they're not even convenience stores. And we know these convenience stores, stock is limited, prices are high, quality not so good, etc. So medical care. We know that in the district, nearly 97% of folks have health insurance. But health insurance alone, it's necessary, but it's far from sufficient. So we're still seeing, we're up to 98% in some areas, and maybe it falls to 84% in others. A lot of those places where we see less insurance, it's where we have high concentrations of new immigrant populations, and they are not as well insured. But we do have those kinds of services available to them. But we're still actually in some respects seeing larger dots up in Northeast DC than in Southeast DC, despite the insurance situation. So we can look at the outdoor environment. We can see that asthma for adults as well as for children. So adults on the left side, children on the right-hand side. Still, we have high concentrations or higher concentrations in the Northeast and Southeast. But the pattern, again, very similar to what we've seen before. We can look at community safety. On the left-hand side, you can see the number of crimes, and it's the same kind of darkest. The most crimes happen in the district, in the center of the city. But we don't hear people saying, we're not going there, right? There's a perception, and I'm not saying it's totally unwarranted, but we have more crime in some parts of the city, but it's not the places that people usually assume they happen. We have more violent crime in other parts of the city. So it's a mixed bag. But I'm really trying to point out that sometimes we have some assumptions in our head that may not be well-founded in terms of what we think is actually driving some of these disparate outcomes. But we're seeing the differences. And it's not the murder rate that is lowering the life expectancy in Southeast DC. So I just want to clear that up. So, but we have suicides are part of some of these maps. So if we do, when we map violent deaths in the district, we are also including suicides as well as homicides, and they happen all over the city, right? So bottom line is we can take an indicator from any one of these 9, and we can put it again, rank them in order from Woodley Park, which got the highest rate in terms of life expectancy at 89.4 years. And we stack each one up on the left-hand side, life expectancy at birth, and then we put an indicator. It's almost like a bingo, what you're seeing here. So the green is showing the best outcomes, and you can see most of the top 10 get green. And then the opposite is true, right? So the bottom, you're seeing the bottom 10 are red, 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 all the way. So it's the same kind of thing. And in between, you have a spattering of red and green. But the main takeaway from here is that regardless of the indicator, we are all, it's not just the rich, poor, black, white, everywhere, depending on where we live, we have some increment of opportunities for help that is different from a neighborhood to the left or to the right of us. And so we each have, so that's why I say health equity is everybody's work. Everybody is a part of it, whether they recognize it as such or not. And this is part of how we have set up our community and delivering services. And these are the outcomes we're getting, right? So bottom line is we have differential opportunities for health. None of these things are working on their own. So you see these overlapping circles now. So they're what I call them, they're interrelated pathways that create these outcomes. Life expectancy at 21-year difference across the 51 statistical neighborhoods. But more opportunities are in some neighborhoods than others. But the opposite is also true. At the bottom of the scale, so all that red is there are fewer opportunities. And it's not just one thing. It's one thing next to the other, next to the other, cumulative impact. So overall, it is clear that there are differential opportunities for health in the district by income, place, and race. So I've gone very slow. So I'm going to very quickly go over what's happened in COVID. So the data I was showing you before related to a 5-year average 2011 to 15. The most readily available data when we updated it shows 2015 to 19. What we're seeing is that we still have significant differences by ward in terms of outcome. And I know you were asking about race and ethnicity, and we're seeing that there's a 15-year difference in life expectancy for Black district residents versus white, right? And the lowest ward, the ward with the lowest outcome is Ward 8. And in fact, this number is actually lower than what I showed you earlier from the first 5-year increment of 2011 to 15. So to give you a sense of how this stuff works and how we applied it during COVID is this, what I call the structural vulnerability index. Instead of looking at all of the criteria, we picked a selection of criteria related to at least the beginning of COVID, what the research was suggesting was driving different outcomes in the city. So on the right-hand side, you can see what we mapped, right? We mapped age over 65, where more than 13% of residents lived. So it was age, it was public insurance, not the public insurance. This is not to disparage public insurance, but the public insurance is an indicator of someone's inability to get good insurance in their job. So it's more of an indicator rather than an indictment. We have the uninsured, we have income greater than 200% of poverty, less than 200% of poverty, essential worker status. We all started to learn what essential worker meant during the pandemic. The unemployed, folks on public assistance, residential segregation, which I showed you earlier, limited English proficiency, and crowding. So crowding. So we put all of these things in a chart to try to think about if we were to cross-analyze them, because what I showed you before, we were showing you each of the 9 key drivers in separate buckets. We're developing a new tool that would do this more efficiently. It's called the Health Opportunity Index, but this is what we started with at the beginning of the pandemic. Sorry, I should have showed you in the bottom. You're talking about a vulnerability score when you add them all together. We also added in cumulative incidence, and then we talked about race and ethnicity and ethnic minorities in neighborhoods. This is the bottom part of the chart. So we looked at the uninsured, we looked at SNAP and assistance and limiting things. Bottom line is, if we did all of that and we were to map it, what we see is not simply that we have Ward 7 and Ward 8, Ward 4 and Ward 5. You can see that there is a pattern there where we have some of the most stressed neighborhoods in terms of COVID or more vulnerable, all the way up in Ward 4, which most of us in our heads assume that because of everybody only talks about Ward 7 and Ward 8, but clearly Ward 5 and 4 were part of the equation. And that started, this we did, I think, something like early to mid 2020 and 2021. We actually used this data to get a grant from the Office of Minority Health to start talking about health literacy, which is some of the major work that we're doing right now. So not only are we able to, and we started in COVID looking at the statistical neighborhoods to map the data, right? I know most of you are not, you're more used to wards, et cetera. But this is showing you what was happening in the first wave of the pandemic. Actually, this should have said February to September 2020. So there's an error up there. I do apologize. The slide itself says the wrong thing, the right thing. So it's right there up in the Northeast, as I was showing you up here, where we had the most rapid spread of COVID-19. And it was partly amongst the Hispanic population and on the 14th and 16th Street corridors. When we moved to again, this is what happens when you copy and paste the label. It should say 2020. Then it started moving to Ward 5 and then Ward 4, Ward 7 and Ward 8. And here's where we now have the highest rates in wave number 3. So this went all the way through to November 2021, right? So we've seen not only differential rates, but we saw the patterns moving in different parts of the city, and the underlying causes were various, right? Folks and I think a lot of what was happening, first of all, in Ward 4 with the Hispanic population, it was frontline workers. And then down in Ward 7 and Ward 8, again, frontline workers, people who don't have access to a car, and some of those challenges that people had to face. And so we could have this final slide that tells us a little bit about what happened overall in the wards, but we can still see a significant difference across the wards in terms of the total number of positive cases. And this was at the end of last year. So I'm using this slide that we used at our Health Equity Summit that we held on December the 9th, right? So we can see, so it may have started in one place, but some wards were protected in many respects from the challenges. We can see similar kinds of patterns happening. And this again is just giving you kind of close to the end game at the end of last year, what was happening. And then I can then show you the data. So overall, even in December, half of the folks who caught COVID in the district were African-American. That's a slightly higher than their share of the population. And it was 25% for the white population and 16% for the Hispanic. But here's what happened with the wards. In fact, what we're seeing here on the wards is that, in fact, Ward 7 had the highest rates of COVID. Ward 8, I'm looking at another slide. Part of my slide is being covered by your photographs, but I like to see people's faces when I'm talking. So I'm looking at my paper version. And then Ward 5 was right behind it, not Ward 7, right? So a lot of the assumptions that people make, and then closely followed by Ward 4. And then you see the other wards pretty much not as heavily hit by COVID as the rest. And then ultimately, even though they were 52% of the cases, African-Americans suffered 76% of the deaths. And by the way, we saw a significant recovery amongst the Hispanic population in terms of COVID case rates, but also they were very much protected by what we frequently refer to as the immigrant paradox. They're also a lot younger, so the impact on their health was a lot less, even though they lived in close communities, close family circumstance. There was a greater opportunity for recovery. So we saw differences in infection rates, recovery rates, death rates. All of those things were very dynamic across the city. And then finally, this slide kind of shows us what happened if we compare the leading causes of death in 2019 versus 2020. What this slide is actually showing is that, and so number 3 is lab confirmed COVID-19, and that's probably an underestimate because this is only the lab confirmed. We probably had other people who died of COVID, or COVID was a secondary complication or something like that. So we have seen a significant change in terms of just overall what the leading causes of death were. So heart disease and cancer typically are at the top of the list, but then COVID became number 3, quick, fast, and in a hurry during the pandemic and after. So post-pandemic planning, we are about to publish our report. What we know is, and what we've learned from the pandemic is that in order to eliminate these drivers, we need to really think about collectively how we deal with access to quality healthcare, how we deal with social and structural determinants of health, and structural and institutional racism. And then, of course, we've published the Corona Pandemic Health and Healthcare Recovery Report back in May 2021. So the summit that I recently held, and actually let me just talk quickly about what's in this report. This report really focuses on the healthcare sector and what we need to do, but it talks about workforce. It talks about using health technology, healthcare facilities, health planning, et cetera, as the key ways in which we need to respond to rebuild after the pandemic and to go on to not just put things back the way they were, because I've just showed you where we were before the pandemic. That's not a good place to aspire to. We need to be much better than we were at that point. So here are the things that came out of that report. They put equity as the centerpiece, as you saw as the report. We have they have 5 broad domains that I just showed you in the circles, 39 recommendations. One of the key ones is dealing with implicit bias, which is related to structural and institutional racism. Both short-term and long-term recommendations have been made for the healthcare sector, including mandatory training and diversification of the percentage of physicians who are people of color. So we had a summit. These are the last few slides, I promise. And it was held on December the 9th. And we did focus on the other 2 legs of the stool, structural and institutional racism, as well as social and structural determinants of health. And this is a very convenient kind of, if you were wondering what is structural and institutional racism, it's the totality of the ways in which societies foster racial discrimination through mutually reinforcing policies. So remember, all policies help policies. So housing, education, employment, earnings, etc. And this is we saw it through the pandemic. We've seen how those dots connect. Folks couldn't shelter in place because they were living in overcrowded households, or they couldn't work from home like I'm doing right now, and they had to go to work. So we were all the same virus, but we all lived in different circumstances. So we had disproportionate exposure one way or the other from the pandemic. So here's what we got. So here are the major takeaways from the summit. We need to promote this culture of health and wellness and what we call DC hope. So hope, opportunity, prosperity, etc. Really what we've seen is those dots are very well connected to each other. This work came out of the Reopen DC process, and it really talked about the importance of thinking about these 2 factors across the entire economy. We need to sustain a whole of community response, because that's what we did during COVID. Everybody participated. We actually had slogans that said things like, we're all in this together. We all need to be part of the solution. There's a lot of subtext to a lot of this, but I didn't have space on the side. We need to repair the past to transform the future. So we know that the inequities, I told you, our genes are the same. So it was not genetic predisposition that made some folks die more readily than others. It was lack of protective factors. And that wasn't only in the immediate wake of the pandemic, it goes back generations, if not hundreds of years. We need to prioritize community engaged practice. And this is really about taking into consideration the lived experience. So we saw a lot of things happen in the city. We provided additional health insurance, and we provide additional income. We passed a ban. There was a national ban on evictions. We did some more locally. All of these good things are really important. And we really need to think about how we more formally work together. A lot of what we did in the summit was really talk about how informally, since we published the Health Equity Report, people have started using the equity lens. That includes the new comp plan, which includes equity and several other things. So We have a new housing equity report, one of the first in the country. We're now talking about having affordable housing, not just in Ward 7 and Ward 8, but in all over the community where we have a lot more resources. So ultimately, this is kind of my last slide, but this is where we are. This is where the new work is. This is where I've been working with the new Chief Equity Officer for the city, Dr. Amber Hewitt. And so we actually partnered in this summit and talked about these issues in unison. We can't say, as I did at the beginning, structural racism acts as a force, and then put that works on the one side. We have to figure out how to integrate it, how to be inclusive in how we think about solutions, et cetera, et cetera. So that's my last slide. So I'm sorry I went a little bit over that I had planned, but I hope that's okay with you guys.
Absolutely.
So I can stop sharing if you would prefer.
Okay.
Then we could just have a conversation, whatever works for you best.
Yeah, that would be fine. Thank you.
Okay.
We appreciate this is quite comprehensive.
And I can send you the slide deck when you're finished.
Yes, please. Yes, please. There are
Yes.
several on there, but
Yeah.
you had asked before we started about what we learned last time from
Mhm.
Ambrose Lane Jr. and Dr. Balda Crowder. And he told us, and it was basically, you just can't look at health. There is this income situation. People don't have enough money. They have access to food, all, et cetera. All the factors are there. The thing that she added to us which was kind of new to me, and I hadn't really thought about it, because I do know there's a lot of people have insurance in the district. They have Medicaid. Okay. And what she pointed out to us that there is a disparity in health insurance. And here is people have Medicaid, but they have to go through a lot of bureaucratic hoops every year to be reinstituted. And they may not have the wherewithal or the time, the patience or whatever, or the ability to completely renew. So therefore, they lose their health insurance, which we taxpayers are paying for. And so that was basically the key message, and that was new and different for me at least. But so that's what I can report on. There's somebody else, like Fran, is there something else that you want to, you're on mute. You can add?
Yeah, I just add, I thought, yeah, the other thing we learned is you can have health insurance, but you can't find a doctor. Either doctors don't take Medicaid or they have too many patients. And that I've always assumed, oh, you got Medicaid, you got health insurance, but that I have to admit,
Yes.
that was.
And so that I did show one slide where I was showing that, yes, people have insurance, but there's quality of insurance. So there are different qualities of insurance. There are different, and even if you have insurance, you may not have a job that would allow you to go to the doctor at the time that the doctor's office is open. So there are a lot of you may not remember the car situation, right? Yes, we all think that we see traffic jams in the district, but the people in the traffic jams are not necessarily folks who live in the district. They may be from elsewhere. And they, and I showed you also transit, and we talked about buses. So all of those things come together to make it difficult. Now, some of the things that we were able to test out and innovate during the pandemic was related to insurance, where people were that we did make it possible for people to renew their insurance via online and some of these other systems. So we are working on, so the pandemic was very stressful for everybody, but it also allowed us to move fast on a lot of things that people resisted, like telehealth, et cetera, for years, right?
Yeah.
So there's some other things that we could change as well. We could also change when doctors' offices are open. We could have better care teams where people get more, you could see, and you may not need to see the doctor today. You may need to see the nurse practitioner, or you may need to some other thing. So those are the kinds of things that, so it's usually not just one thing, right? It's usually a complex mix of things that will transpire that will prevent you. So if I am one of the lucky few, I have a good job. I have some flexibility. I am able to, if I need to go to my doctor's office, I can basically say, and in fact, this working from home is kind of helpful because it means that I can work. I'm still technically working, even though this is fun to be with you guys, right? I can work tonight, but I'm on the senior leadership. Nobody really, I'm not saying they don't count my time. I do many more than my 8 hours per day, but what I'm really saying, I can say I'm running out to the doctors, I jump in my car, I go to the doctor, I come back, I do telehealth, whatever. Other folks don't have a job that allows them that kind of facility. If they're a frontline worker, if they're one of those essential workers, their job does not allow them that kind of flexibility. So it's having insurance is necessary, but it's far from sufficient. Because if that were so, we in this country, which is why I showed you remember the slide where I said, in America, we like to talk about the causes of people having health disparities, whereas what we should be thinking of is the structural barriers, the laws and the policies that we all think are just norms, right? And most people, it's not that they are purpose. I'm not saying that people are purposefully doing these things, but we have developed into a model where health insurance is closely connected with people's jobs, and the quality of your job begets the quality of your insurance, or no insurance at all, so that you may be on Medicaid, and Medicaid is set up to in a way where they're basically, and that's why they had those rules. It's really to kind of means test folks, make sure they're following, make sure they're not making, extra money. So some of the things that we are currently working on at DC Health is to also combine some of those services and putting things like WIC and food stamp kinds of things on a single card that takes away the stigma, and it's just uploaded to the card. Whereas before, one had to go to the office one more time and sign up and get this and get that and the other. So those are some of the solutions that people turned on a dime to some extent during the pandemic. And now, and we've been talking about it for years, but it was very difficult to move the systems in a timely manner to make them happen.
That's great. Thank you. Joanna?
Judy? Okay. All right. I'll jump in. Dr. Arno, I see your job. I assume your job is in part to propose, advocate for, and hopefully make happen these improvements in health systems, the insurance, perhaps distribution of healthcare. But another job I assume or suspect you consider yours is to advocate for these bigger systemic changes. We need more affordable housing. We need to improve our transit system. Any luck?
Well, yes, there's a lot of good news. Let me tell you a little bit about it. So I talked about the housing equity report. So I think the mayor in 2021 invested $400 million in the Affordable Housing Trust Fund. I think it's up to $500 million this year. Good. There's also the plan to put affordable housing in all parts of the city. So there's a lot of investment in housing. In terms of transportation, I know there was a look at whether we could give people trip cards if they meet certain criteria. You may be an adult and you may be disabled and you don't necessarily fit all the other criteria. So that's another. One of the projects that is near and dear to my heart, because we worked on it, started just before the pandemic and finished, well, we're not finished, but we're going to go on. It was funded by the Pew Charitable Trust. It was a collaboration between my office, the Interagency Council on the Homeless, DHS, and a few other homeless shelter house. We had a rule in the district that said folks were not prioritized for housing until they reached the 3rd trimester of pregnancy. Did you hear that right? The 3rd trimester, right? So potentially people could be homeless on the streets of DC for the first 2 trimesters before the rule allowed them to be prioritized. We started that work in 2019, and just in February, DHS announced that they were going to move their model to start considering folks in their 1st and 2nd trimester. A lot of what I've learned, especially through that project, was that systems don't even realize when what they're doing has a negative impact on health. They have these rules. Their rules in their head were set up to prioritize people in their third trimester. And that's the way they kind of take people off the list. But when they started out, they didn't know how many people they were turning away, etc. I want to add, these are my colleagues and friends at DHS, right? But as soon as we brought it up to them, they started collecting the data. And they started, in fact, within 3 months, they started collecting the data. They knew how many people they were turning away. And then, but it takes time, you know, to change these processes. And they've just started. They're not only are they going to start keeping records of who is in it when folks come for housing, what their priority is, but they're also going to try to build in perinatal care and all the other things that go with that. So again, some of it is, and they all thought they were doing great work. Yes, we didn't let anybody, I mean, that's how the rule was set up. They didn't let anybody before their third trimester, but they're thinking about housing as a resource rather than as a something over your head, rather than a health resource. And this is what we call a health in all policies approach. So those we've been working on, my office has been working on Vision Zero, on that kind of thing, and thinking about who are the folks who are mostly run over in the district. There's a lot of and I'm not opposed to people who ride their bicycles, but there's a lot of emphasis on the bikers, very little emphasis on the pedestrians who get run over. And most of the pedestrians who get run over are people of color living in other parts of the city where we probably may not be enforcing as much as we should, et cetera, et cetera. So again, it's all of the, so most of my work focuses outside of traditional healthcare, but I'm frequently working with my partners. So yes, I said I led the housing work, but I'm also partnering with our community health administration and maternal health, so that they come in with the actual, and here, when I go and ask, and they can give me, oh, here's what we have to say about this. Here, we're doing that kind of work. So it is, as I said, it's patient work. It took us two years to move the die, but they've been doing that for years. The third trimester thing has been the rule. It's been the rule. It's still the rule, actually, but they've changed the internal policy, because some of those rules come from the federal government, right? So DC can adjust some of the things that we do locally. And I think those are some of the things that we really need to think about how, and we've invested a lot. We've learned a lot. I mean, during COVID also, I mean, it was a horrible, it persists, but it really made people realize how connected all the dots are. When you send kids home, if they don't have good quality broadband, they can't learn. Or if they don't have a home computer, they can't learn. So it's everything. If you send the kids home, the parents have to be home. If the parents are home and they're frontline work parents, the kids may be home, but if you're a frontline worker, you're in a very awkward situation about what do you do with the kids who are home if you have to go to work to put food on the table. So it's a, and if you don't go to work, then you're now one of those homeless people. Everything is connected with everything.
I think the theme of your job, theme song of your job should be the knee bone is connected to shin bone. Remember that?
Correct.
Yes. Judy Berman, did you have a question?
Yeah, I did. Dr. Arno, thank you so much for being here. I'm Judy Berman. I'm the executive director of Capitol Hill Village, and we're just so pleased to have you. I sort of had a question about, the public health approach, the population approach is so powerful, but it also can give you the sense that the die is cast. Now, our focus is on older adults. And I have been very interested in how we can use our resources to make a difference for older adults of color. And I wonder if you have any thoughts about that. What is it that in this, sort of community-based way we can do for people whose health is already what it is, like at 75, I mean, if they're lucky enough to live to, 65 plus, right? But if you have any thoughts about that. And before you answer, just share one quick story. which is to reinforce the transportation issue that you talked about. Capitol Hill Village got some funding to provide rides for medical appointments. And we did it with no barriers. It was like, you call us, we'll send you a lift. Basically no questions asked.
Sure.
And we had several people who told us that they were making appointments that they wouldn't otherwise have made because we made it so easy to get there, right? They didn't have to spend 2 hours waiting for a ride on the way back, so it was things that they might have put off, screenings or whatever that they were able to do. So I felt really good about that.
Okay, good. So I am involved in I don't know if you've heard of it, Age Friendly DC. Right. So I am involved in that.
Gail
I've
Cohn,
given-
did you know that Gail Cohn was our first executive director?
Oh, that I did not know.
Yes.
Oh, good. Well, there you go.
Yep.
Small world, small world.
Exactly.
That's fabulous. So yes, I have given this presentation. We work with them all the time. I have talked about with them or given presentations at GW on food as medicine, how food is important. But I also I hasten to point out that, again, we can talk about all these things, but if there aren't enough resources in the household to be able to afford that good food, we need to kind of give people what are the alternatives, right? So we love to talk about fresh fruit and vegetables. We frequently like to talk about farmers markets. But for me, those are great. But what we actually need is investment from the city in full service grocery stores within easy access to where people live. And so the mayor just recently, I know, took eminent domain over a new supermarket that they're going to build on East Capitol Street, right? So to me, it's more, which is what I said. Yes, I like WIC. Yes, I like all of those things, but those are temporary solutions. They are not permanent. And even if people have funds, if as you said, if they don't have a car and the supermarket with the full service grocery store is not nearby, they're left to only go to corner stores where if they have vegetables, they're limited in scope and they're probably old and rotting. And even if you buy a big bunch of it today, kale, by the time you get home and look at it for one day in the fridge, it's probably not worth eating. So it's those kinds of things. One of the things that I think is really important, which is why I say health equity is everybody's work. And I like your question. It means that when you hear somebody advocating for something for older adults, which may not be the folks who are in your community, you need to think about the folks in the other community and vote in that way. I learned this from when I was the director of the Center for Health Equity in Louisville, Kentucky. We were located in the African-American community. Nothing wrong with that. It's great. But what the presumption was that we were only preaching to the choir. What I need to preach to is all the other folks, because if we have legislation that only the choir wants passed and all the other people, all the other parishioners don't care, right? Then the legislation won't pass. So which is why I'm so excited to I go to speak to whoever invites me to speak, up, down, around, whoever it is, because everybody has a vote and they're either voting for or they're voting against, or they're not, or they're making, well, yeah, no, I don't need that. It doesn't matter to me. It needs to matter to you. This is what I mean by health equity is everybody's work. You need to see that your vote counts, not just for the things that narrowly matter to you, but how it matters to everybody in the city. And that's what this health equity is everybody's work. And that's what by commission or omission, it's not only what you do, right? It's what you don't do. If you don't turn up to vote for a new policy that is critical to other parts of the community, that's how it works. So I hope that provides some of an answer.
Thank you very much. Are there any other questions before we let Dr. Arno go? Okay, well, I want to thank you. This has been very informative, and we look forward to having the slides there. We may have some follow-up, and I hope that you will welcome us to ask some more questions offline or however, but it's been very, very interesting and informative, and we really appreciate you coming and making the effort. Joanna has something she wants to close with.
I think informative, but also inspiring and reminding us that yes, the vote and advocacy and being involved in the community discussions about what's happening time and again, it is important. And I know that many of us do that, but hearing from you and seeing the numbers and tying it to human experiences, it is inspiring indeed. Thank you.
Okay, good.
Thank you.
And what I'll do is I'll send you the slides. I will send you also a link to the original health equity report. And I can also send you a link if you really love this kind of stuff. I'll send you a link to the summit that we had. We now have it all up on
Yes, please.
YouTube, and you can watch it in sections if you care to. So then you'll hear about what all the other sectors have been doing. And then ultimately we will publish, we're hoping to publish our report shortly, and then we'll have an update to our health equity report. But this has been wonderful. So glad that you are doing this work about issues of race and justice in our city. I commend you for even having such a title and having such a wish, and that you've been doing it for 2 years is fabulous.
Thank you so much.
Thank
This has
you.
been just a wonderful, informative session. Thank you.
Yeah.
Yeah.
Thank
Thank
you
you.
for listening.